Sorry, no, we are not able to hear you at the moment.
Emily, what I will do is I will let you work with Clara, and I will introduce Dr. Jonathan Jun from the Johns Hopkins University Department of Pulmonary Critical Care and Sleep Medicine. Dr. Jun was kind enough to step in on a moment's notice and share what I think we're going to find to be a very interesting talk on metabolism, and it works with Siva Polutsky and Dr. Naresh Punjabi. So as you've noticed, his work and his colleagues and his team are quite well known for a lot of their contributions to sleep medicine. So without further ado, here's Dr. Jun. Thanks.
Sure, thank you. Everyone can hear me okay?
Yes.
Okay, great. Well, thank you for the opportunity to speak. I will talk to you guys about, as a pulmonary person, why I've been interested in metabolism and circadian rhythm. I have no relevant conflicts of interest. And today's objectives are going to be, first, to recognize the bidirectional links between sleep apnea and metabolic syndrome. Number two, to evaluate the potential for diet to affect breathing, particularly in OHS, which we heard about from yesterday by Dr. McLezy, and to examine effects of meal timing on metabolism. So I'm going to return to this rubric several times in this talk, outlining how all of these factors, diet, metabolic health, respiratory health, and ultimately cardiovascular disease, are interrelated. We will address how food timing, which is a sort of novel way to look at how what we eat and when we eat may affect our metabolism, how that impacts upon metabolic health. We'll also look at how metabolic health affects respiratory health. I think all of us know patients with obesity are going to potentially acquire OSA, or obesity hypoventilation syndrome, so the arrow in that direction. And there also may be an arrow that goes the other direction, where respiratory health can go back and interface upon metabolic health. And ultimately, this all matters because we all know metabolism is what drives most of cardiovascular disease. So the first thing I'll start with is looking at this direction, which I think is the easiest arrow to address: metabolic health impacting upon respiratory health. This audience, I'm sure, knows that obesity is the main driver of OSA in the adult population. But it's not just obesity when we look at BMI. We have to go further and break it down into whether your obesity is due to subcutaneous fat or visceral fat accumulation. And by visceral fat, we're talking about adipose tissue that accumulates in certain regions of the body, particularly behind the omentum of the abdomen. And that seems to go hand in hand with putting fat down in other areas, like your liver, your neck, the pharynx, and the tongue. So if you just looked at a population of people with a BMI of 35, and you grabbed 100 people with a BMI of 35 and compared people with sleep apnea to people without, you might come to the wrong conclusion and say everyone with sleep apnea has metabolic syndrome and they got it because of their sleep apnea, right? I think there's a tendency for us in the sleep field and the pulmonary field to lay the blame on sleep apnea as the cause. And I will address that there can be a contribution of sleep apnea to metabolism, but remember that visceral obesity is a big contributor to both sleep apnea and metabolic syndrome. So when you're reading a paper that looks at the relationship between a metabolic outcome and sleep apnea, and they say they matched by BMI or they adjusted for BMI, be very careful about how you interpret that, because at least some of the confounding from where the fat is in these patients has not been accounted for by just adjusting for BMI. So that's not to say that OSA has no metabolic impact. I've been very interested in what the truth is. How can we learn what sleep apnea actually does to metabolic health? Now, CPAP is a great way to test that, but there are, as you know, great limitations to how we can randomize people to CPAP or sham CPAP with adherence, with selection bias, and so forth. So our lab has taken a different approach. We have looked at removing CPAP from patients that are previously adherent, a technique called CPAP withdrawal. This has been done by several other groups, so we're not the first to do this, but we wanted to look in a detailed way at what CPAP withdrawal does to metabolism. So we took patients that are aged 20 to 65 with an AHI of at least 20 who are adherent to CPAP and randomized them in a crossover design to a night in our lab where they wear their CPAP, which is shown here, or a night in our lab after a washout period to a night where they do not wear their CPAP, and actually they discontinue CPAP for 3 nights beforehand. So they're coming in on their 3rd night after CPAP withdrawal. And I illustrate the patient here because we have a very elaborate setup which includes full PSG. We have a window here where we can run an IV through, and we actually draw blood samples at every half hour to look at a detailed profile of metabolism when someone is wearing CPAP or not wearing CPAP. I won't get into it today. We've also done stable isotope studies to look at glucose turnover in this state, but I'll address some of the other data today. So first and foremost, if you tell someone to stop wearing CPAP for 3 nights, it comes as no surprise that this is what happens to their sleep. You know, the AHI goes from very low to very high in our population. Their arousal index goes up, and of course, their oxygen goes down, right? So the experiment worked. We were able to recapitulate bad sleep apnea when someone does not wear CPAP. So what happens to metabolism? So if you take CPAP off someone, what I've done is I've plotted the profile of a variety of commonly measured metabolites in the circulation. Red being the night where you wear CPAP, blue being the night where CPAP is not worn. You can see that FFA, which are free fatty acids, are elevated, glucose is elevated, and cortisol is elevated. We did not see statistically significant changes in lactate, insulin, or triglycerides. And of course, and what's important to note is before you sleep and after you sleep, with several of these parameters, the levels are similar, but they do seem to converge upon awakening. So timing of the blood sampling does seem to be important, and some of these effects we could characterize as being transient. Why do I care about this FFA parameter? Because free fatty acids emanate from adipose tissue under conditions of stress, sympathetic activation, fasting. The correct response is your body releases fat from your fat stores in the form of plasma FFA. The problem is when FFA levels are high and they exceed the demands of the tissues being supplied, you can develop a variety of downstream consequences such as vascular inflammation, muscle insulin resistance, and liver steatohepatitis or fatty liver. So we believe that there may be a link between excessive lipolysis, too much fatty acids entering the bloodstream during sleep with OSA, and downstream consequences. This is a busy slide, and I did that on purpose because this illustrates the heterogeneity of FFA levels when people discontinue their CPAP. So once again, the OSA night is in blue, the CPAP night is in red, and you can see all kinds of patterns to what happens to people's FFA levels when CPAP is removed. Some patients appear to be very sensitive, and if I just hover my mouse around this panel, for example, or this panel, you see marked changes in FFA, and other patients do not seem to have a robust response, like a lytic response to CPAP removal. So what we did next was we did some fancy statistics, because what we have is each night we have about 20 blood samples, and we can actually chop up the PSG into 20 segments and look at what is the statistical relationship between the blood work at any given time and the sleep structure in the 20 or 30 minutes preceding that blood draw. So in other words, we can really look with a fine-tooth comb at what happens to metabolism every 30 minutes and what was going on with sleep in the preceding 30 minutes. So for example, if you took a look at this front panel, For every one respiratory event, meaning an apnea or hypopnea, in the preceding 30 minutes, we saw a small but statistically significant rise in FFA and glucose. I'll jump over to heart rate. For every one increase of BPM in the preceding 30 minutes of sleep, we saw elevations of FFA, glucose, insulin, and lactate. So it appears that there is a tight correlation between what's happening minute to minute during your sleep and with your metabolism. Cortisol, as you can see here, cortisol, interestingly, has no relationship between oximetry, heart rate, or respiratory events. Cortisol appears to be tightly linked to sleep structure. So for greater amounts of stage N1 sleep, we saw elevations of cortisol, and for greater amounts of N2 or N3 sleep, we saw falls in cortisol. And I think that should come as no surprise to those of us that know relationships between wake and cortisol regulation. And of course, if you were awake in the preceding 30 minutes, then your cortisol was elevated as well. So this data was published in JCEM, and I do want to credit the people that worked on this, including Dr. Pham, who's junior faculty, and a number of both post and predoctoral fellows that were instrumental in this award. I also want to give a shout out to Dr. Moody Salho, who is junior faculty that is taking this work in another direction on the R01 that I'm funded on to look at a greater number of these patients. So we already enrolled about 100 patients into this study and are going for a larger sample size of 144. Also giving beta blockade before sleep to see if there's an impact on attenuating these metabolic changes, and use of stable isotopes. I'm going to go back to this diagram that we saw earlier, interactions of diet, metabolic health, and respiratory health. And we already talked about just now how OSA can impact upon metabolic health. I want to shift gears and look at how metabolic health can affect OHS and in turn affect respiratory health. So as Dr. McCleskey did a very nice job of yesterday, talking about how morbid obesity is on the rise and is a big contributor towards obesity hypoventilation syndrome. And we all know that OHS patients are susceptible to cardiovascular disease and early death. And by way of review, we know that OHS, which is shown here in the yellow circle of this Venn diagram, really represents an intersection of both obesity and OSA pathologies. There are certainly patients that are represented by this sliver here that don't have OSA, but the majority of patients do have both conditions. So why did I shift gears to look at obesity hypoventilation syndrome? I stumbled upon this paper in 1976, published in New England Journal of Medicine. These authors took 18 obese patients, 6 with who they called OHS patients, although they technically just had reduced CO2 sensitivity, but did not actually have resting hypercapnia. But anyways, they took 6 patients that they defined as having OHS and 12 control, obese, normocapnic patients. And they did what I would consider a pretty draconian thing that wouldn't pass an IRB in today's age. But they allowed them to eat a hypocaloric diet of 2,500 kilocalories per day at the outset initially. And then for 3 to 7 weeks, they basically fasted them down to 400 kilocalories per day. So they starved these patients for weeks at a time and giving them only a little bit of protein supplementation. And they were interested in what would happen to the breathing in these OHS patients. So in table 1, I'll start by showing you one of their primary outcomes was the response to CO2 inhalation. So the normal response Those were the 12 patients that did not have a blunted response to CO2. The slope of the minute ventilation per elevation of CO2 was normal or sensitive, right? So 3.1 liters per minute per 1 millimeter change in mercury, right? So our bodies are very exquisitely sensitive to changes in CO2. 3 liter per minute change in minute ventilation just with a 1 bump in PaCO2, right? So that was about 3 all across the board in the normal responsive patients, but 0.8. So markedly blunted, as Babak pointed out yesterday, is a root problem of OHS. During the ketotic phase, they became more sensitive to CO2. And they actually refed the patients for a few weeks, and the issue returned. The blunted response returned. If you look at the ABGs of these patients, the PCO2 in both groups, actually, the normal responsive and the hyporesponsive group did fall. It fell to a greater extent in the hyporesponsive group and then rebounded during the refeeding phase. And I will point out that when people think about a ketotic state, we also think of acidosis. It was fairly minimal if you look at the pH changes during ketosis, and this is the plasma bicarbonate level. Did also modestly decrease, but certainly not a dramatic acidosis to induce these changes in breathing. So that got us to thinking, and one thing I'll say about that study was, of course, the patients lost a lot of weight during that starvation phase, but the amount of weight lost did not seem to be proportional to the changes in breathing. So we became interested in this study to see if we could apply this to a more, I guess I could say, humane way of dieting. And I've shown Bobby Barron's picture here because she's a nutritionist, a research nutritionist that works with us. Could we recapitulate these findings from 1976 using a ketogenic diet where the carbohydrates of the diet are markedly reduced? As many of you know, a ketogenic diet emulates many properties of starvation because you're removing carbs, which create the insulin response, and you're supplementing that or substituting the carbs with fat. So Bobby helped us design a 2.5 to 1 ratio ketogenic diet. That means 2.5 to 1 ratio of fat versus non-fat macronutrient balance. So majority fat, but low on carbs and low on protein. And I'm showing David Kim, who was a fellow that worked with me on this project last year, supported by the AASM. We designed a study to look at what would happen if you put an OHS patient with OHS on a short-term ketogenic diet for about 2 weeks. And measure a variety of metabolic and breathing parameters. Could we stimulate breathing? Could we lower CO2 levels and do so while patients maintained a normal caloric diet? And I want to apologize ahead of time to Babak McLacey because he thought I was going to talk about mice today and leptin, which I've worked on too, but I wanted to focus on the clinical experiments today in OHS. So this is a pilot study. We're up to 5 or 6 patients now, but I've just shown the few that we've enrolled up to this point where we have completed data. We enrolled 3 women and 1 male with OHS. They all had concomitant OSA, and they're a sick population. You know, they have a history of a hospital admission. One of the patients was on Diamox. They're on either CPAP or BiPAP as well. And we give them a study calendar that tells them, you know, when they're coming in and when they're going to be in that ketogenic diet, which is shown here in the blue. Patients are responsible for measuring their own home beta hydroxybutyrate level, which is done with a finger stick, just like a diabetes glucose stick would be. And they wear a continuous glucose monitor on their arm, CGM, which registers their glucose levels throughout the day. So here's the data we have in that N of 4. You can see that In panel A, the BHB, which is the beta hydroxybutyrate level. That's the most common ketone body in our circulation, and therefore has been used as a marker of overall ketosis. And you can see that when patients adopted the home-based ketogenic diet, their BHB levels generally did come up well. We had some patients that did better than others with regard to BHB level. The CGM, the continuous glucose monitors, were another nice way to ensure that patients were adhering to a ketogenic diet because, as you can see, the glucose levels remain relatively flat on a ketogenic diet. In panel C is the body weight. We saw very modest, but there was a few kilo drop in body weight on the ketogenic diet, and a small reduction in BMI. We also measured body composition and saw that a fair amount of this body weight change was related to diuresis, which is another known effect of ketogenic diets. So when we looked at the venous blood gas, we wanted to do arterial, but for reasons of pain and ease of measurement, we went with VBGs. We looked at the pH, which was very little changed. And in panel B is the venous CO2 level. These patients started in the 50s and they came down to the 40s. And then on going back to their diet, which to remind you was only about 5 to 7 days later, their PCO2 levels rebounded. And the base excess or bicarbonate level also fell modestly during the diet period and returned to baseline levels afterwards. So we believe that this is success. We looked at these blood gas levels appear to be similar to those that were seen in the NEJM paper from the 76 period, but obviously without starving people. They were on a ketogenic diet. Patients recorded their food intake. I forgot to show this earlier, and this also shows that there was a successful shift in their calorie intake away from carbohydrates and towards fat. Since one of the mechanisms of CO2 homeostasis in the body is related to how much carbon dioxide is being produced, we also measured calorimetry in these patients under a hood, so we could see how much oxygen they were consuming and how much CO2 they were producing. And you can see here that the O2 consumption was not changed. The VCO2 fell modestly, and the respiratory quotient, which is the CO2 produced divided by the O2 consumed, did fall. And one would expect that. When you are burning primarily fat instead of glucose, your respiratory quotient generally falls, and that reflects a lower amount of CO2 being produced per calorie eaten. So one of the mechanisms of the reduction in CO2 level in this cohort may have been a shift of the fuel towards fat, resulting in lower CO2 production. We plan to also measure sensitivity to CO2 with breathing, as was done in the NEJM paper, as well as explore other mechanisms in this project. So the future of this project is obviously to ramp up enrollment. We want to look at other outcomes, including the sleep architecture of these patients, perform CO2 challenge testing, look at some of the hormonal axes that could be involved. Leptin was mentioned by Dr. McLazy yesterday, and of course we are interested in that as well. Insulin, IGF-1, those have also been implicated in mechanisms of CO2 elevation in OHS. And also there's the ability to even consume by mouth ketones without having to change your diet. And there's a whole interest in this from the athletic world of using this as a performance enhancer. So we think there might be a future in using ketone supplementation to emulate these same effects. So Dr. Gu is a postdoc fellow that works with me. She's actually submitting a K99 application this summer that is going to be looking at elements of these future directions in this project. All right, the third part of my talk is to return to this diagram and go back to the top part of it, the diet piece. So all of us know that diet affects our metabolic health, and what we eat is, of course, probably the paramount part, how much we eat. But when we eat also may matter, and this has become a growing field that has been labeled as chrononutrition in some circles, to say that maybe if we eat at the right time, it'll be better for our health. So our group has been interested in understanding mechanisms by which food timing can affect metabolic health. There is already a literature that has tied cross-sectionally people that tend to eat their meals later in the day are more likely to be obese or have diabetes. And this data comes from a variety of different cohorts. It tends to be cross-sectional in nature and not mechanistic. And a variety of data types here. So for example, one study looked at patients that routinely, or people that typically skip breakfast versus those that eat breakfast. And the breakfast skippers tend to be heavier, right? So a lot could be said about that, and the flaws of, gleaning from that study that you have to eat breakfast to stay lean. This is correlation and not causation. So to get more rigorous about this question, we performed a study in our lab to look at how your body handles food at 2 different times of the day. And we called this the dinner time study. We wanted to basically look just specifically at the evening meal, because it seems like that window towards the evening appears to be that witching hour, if you will, in a variety of studies that says that's the time not to be eating. But surprisingly, there's very little well-controlled studies in this space to look at that impact directly. So we did a randomized crossover design study of healthy volunteers, brought them to our lab, and administered them a routine or a late dinner, as you see in the diagram. Routine meaning 6 p.m., late being 10 p.m. And we did a washout and a crossover. They all underwent polysomnography after that. And we also performed hourly blood draws to look at the metabolic impacts of this. And also we labeled the food that they ate with certain isotopes to measure how the body handled the meal. This is that same diagram in greater depth. They were admitted to our lab the day before the dietary intervention to get acclimated to the lab. So they were given a standard breakfast, a standard lunch, a standard dinner, and a standard snack, followed by a standard breakfast again the next morning. And in the upper panel, you see that the dinner we gave them was given at 1800. It was consumed with a shake that contained a labeled fat isotope, palmitate, which was labeled with what we call deuterium labeled palmitate. And that was followed by an evening late snack at 2200 hours. In the lower panel was the other condition, the late dinner condition, where we reversed the snack and the dinner. So you can see the snack was given at 1800 and the dinner at 2200, along with that isotope of fat that we can use to measure fat burning. People have asked me why we did the snack. We really didn't want people to be starving and really hungry by the time dinner rolled around at 2200 for the late condition. So we wanted to keep this a little bit more like the real world. If you're going to eat late dinner, you probably have eaten something before that between lunch and dinner. So we kept a snack in the design. All meals were of the same macronutrient composition, 50% carbs, 30% fat, and 20% protein. And the size of the meals was also tightly regulated. A quarter of the calories were consumed at breakfast, 30% at lunch, and dinner was, as is the American pattern, the largest meal of the day, 35% calories of the 24-hour period were dinner. A snack was 10% of the total day's kilocalorie intake. So we had 20 people in the study, aged 26, 10 men, 10 women. They were lean. Their body mass index was 23. The last line is the MEQ score. That's the Munich chronotype, the questionnaire to look at what chronotype that might be. 44 means that these patients were intermediate type. They weren't night owls. They weren't larks on average. We look at their pre-admission actigraphy. So they wore at-risk actigraphy to make sure that they were to quantify what their habits were and to ensure that there were stable amounts of activity before each visit. And you can see there was no difference between routine or late dinner with regard to the typical sleep onset time, typical total sleep time. We also ran PSGs on everyone, and you can see with regard to commonly measured metrics of architecture, we saw no difference whether you ate routine or late dinner. So we found that to be interesting as well. There were no macro changes in sleep architecture. So in terms of glucose, in the left panel, I'm showing you the raw data of plasma glucose levels. Red is the late dinner. The dark blue is the routine dinner. And in the right side, all we've done is we've time shifted everything so that they line up with regard to the meal ingestion time. So looking at glucose first, you can see that eating late dinner led to a higher peak and longer peak of glucose, that's shown here, than when the dinner was consumed earlier. And if you time shift these lines so they superimpose on each other, you can see that there was a significantly higher glucose level for the same meal eaten at the two different times. Insulin, we saw no major change, so your body handled the meal in a similar manner. The pancreas puts insulin out to a similar extent under both conditions. You could argue that that's not normal, because if the glucose went up higher, the amount of insulin should have gone up higher. So in a way, this shows that the glucose level was higher, but insulin was not following what it should do, with the exception of one time point there at the 4-hour mark. In terms of lipids, so with a meal, your triglycerides generally do rise within an hour or two after eating a meal. Once again, red is late dinner, dark blue is routine dinner, and you can see that the late dinner was associated with a later triglyceride peak here, with an actual crossover of the two levels by the morning. And superimposing those two curves, you can see that late dinner led to a lower level of triglycerides early on and a slightly blunted peak later, but the overall difference was not significant. So it seems that triglyceride levels are delayed in terms of when they elevate, but they ultimately do increase to a similar extent. Free fatty acids at the bottom, so when you eat a meal, it should result in a suppression of lipolysis, because insulin comes up when you eat, and that should tell the body to shut off exiting fat from your adipose tissue. So that's exactly what we saw. Whether you ate early or you ate late, free fatty acids, plummeted and then began to come up later. And we saw a modest change in free fatty acid levels, perhaps a greater reduction in those with the late eating. But they seemed to cross over later. So again, there was sort of a wash when it came to looking at the overall profile. So with lipids, basically a delay in the triglyceride peak and no major change in fatty acid metabolism. What about the labeled fat that we gave the participants? So here I'm showing you in the left the palmitate oxidation. So when you eat fat and the fat is burned, the hydrogens on the fat get converted into or get cleaved off of the fat molecule and go into water. So you can actually measure the amount of enrichment of this isotope in the water of your plasma, and that tells you how much fat you've burned from the meal that you were given. So in the left, you see the slope of the palmitate oxidation as it goes up after you've had a meal. I thought this was quite interesting because I don't think any other lab has looked at it in this much detail before, but if you look at the arrows and when the fat starts to be converted to water, within a few hours of that meal ingestion, you've already burned 20% of that ingested meal. And by the next morning, you've burned, between 60 and 80% of the fat that you ate has been burned. If you superimpose these curves, you see a subtle but statistically significant divergence where the late dinner resulted in lower conversion to water. That means that less fat was burned when you ate the late meal. What's quite interesting is that this is not a one-size-fits-all. So depending upon what you were doing before you entered this study, we saw a variable effect. So on the left panel, I've shown you the amount that the glucose goes up after eating and how much the magnitude of the increase that it went up when you ate late compared to when you ate early. And in the x-axis is the habitual sleep onset that we determined by actigraphy. So if you were a 3 a.m. sleeper, that's down here, and you were given a late dinner, you had very little change in your glucose elevation with that meal. If you were a 11 p.m. sleeper, that's a -1 on the midnight axis here, you saw up to a 30% increase in your nocturnal glucose peak. In terms of the fat burning, we saw a similar signal, but a bit more scattered to that. So if you were a habitually earlier sleeper, and in this cohort that means 11 p.m., we saw about a 2% reduction per hour in the fat burning rate. And if you were a post-midnight sleeper, not much of a change, right? So people that are earlier chronotypes, if you will, that sleep earlier, appear to be more susceptible to being given a 10 p.m. dinner. And that might not come as a surprise because you can imagine that circadian rhythm or perhaps just entrainment of habit and deviation from that habit may drive some of these effects. This was published also in JCM and received a lot of press because I think a lot of people are interested in when they should be eating to mitigate the risks of obesity. Since this is a sleep group, I did want to show you a paper that just got accepted for the effect on sleep. I did show you a slide earlier that said there were no PSG changes in sleep architecture. We wanted to look a bit more closely, so we did spectral analysis on the EEG. Here you see routine versus late dinner, and this is just a graphical representation of the different sleep stages plotted in, I think these are 5-minute bins. There's a subtle change, and that's reflected in the slow wave and lighter stages, but you can see that with late dinner, there's a bit more clustering of slow wave sleep towards the first part of the night, and that tails off towards the latter part of the night. It did not bear out when we looked at it in the traditional way of just looking at the whole night sleep architecture. We were able to model that statistically. This is Dr. Lou Pham in the bottom, who's a very talented signal processing guy in our division. He looked at the amount of delta and alpha power over the night, delta, theta, alpha, and beta power, and you can see that the delta power with late dinner was higher in the beginning, as well as reciprocal changes in alpha that occurred later towards the night. So it seems like if you eat a late meal, your sleep is actually deeper in the first few hours, and then that effect seems to wear off towards the latter part of the night. Future directions in this project, I have an endocrinology fellow named Daisy Duan who's very interested in this data. I know the next speaker is about circadian rhythm, so this might dovetail nicely. As you have seen, the susceptibility to eating late varies a great deal between patients, and we think that is reflective of an underlying difference in melatonin rhythm or circadian rhythm. So in the future, we'd actually like to apply some precision medicine techniques to this and assess people's circadian rhythm before they undergo this intervention, actually measure their dim light melatonin onset, and use that to define when late or early meals might be for that person. So in the schematic here, you see we're proposing to measure DILMO, and then tell a person, well, late dinner for you is your DILMO plus 1 hour, and an early dinner for you would be DILMO minus 3. And we'd like to study this in the lab as well to see what the effects might be on metabolism. Daisy hopes to submit a K23 award on this topic. So that brings me to a close on this talk. Going back to this diagram, I hope I've convinced you that food timing matters towards metabolic health. We all know that metabolic health affects respiratory health, and I think the ketogenic diet may be a promising avenue to leverage that knowledge in terms of helping patients with OHS. We also know that OSA can affect metabolic health, and I think we need to be careful about how we interpret studies that look at that cross-sectionally. So I think that brings me to my last slide, where I would like to acknowledge all the people that helped in these different projects. Notably, Dr. Pulaski in the top left has been my mentor and now collaborator. Lou Pham, who's done a lot of the advanced digital signal processing. These are the nurses that kind of cringe when they see me walk into our CRU because they know that it's another one of my studies where we have to measure something every hour. It's a lot of work to do these studies. So I'll stop there and be happy to take any questions.
I think you hear me better with the mic on. First of all, Jonathan, thank you for a very thoughtful discussion. And so, I think it's really interesting as a colleague and a sleep physician, I think you help enlighten why the endocrinologists and our group get along so well, because they can send us a lot of business and also they can teach us a lot about what's going on here. We look like we've got a couple of questions popping up. So the first question we have is from Victoria Marshall, and she asks, is it recommended that night workers eat larger meals at the end of their shift? So in other words, the question I think looks like it's related to folks who are night shift workers, and how should they manage their meals relative to, their work rhythms relative to their circadian rhythm. So the question here is, for night workers, should they eat a larger meal at the end of the shift or before the shift starts or during shift work, assuming that they are working from the 8:30 p.m. to 6:30 a.m. time frame? Can you offer any thought on that?
Great question. I wish I knew the answer to that. So I think the question becomes, are the effects that we see on metabolism mediated by circadian rhythm, or are they mediated by activity, sleep-wake state? And our study design did not allow us to tease that out yet. So you can imagine that some people that do night work, you would expect that those people were drawn to that work because inherently they may have a delayed chronotype. And if that's the case, then they may be somewhat immune, if you will, to the late meal effects that I've shown today. On the other hand, there are people that do night work that may not have a delayed chronotype. They're doing it because they have to. And they don't have a choice. And those people may not have an underlying delayed circadian rhythm. And in those individuals, they would be susceptible to eating out of phase. So I know that's a bit of a wiggling out of an answer there. I think it will depend on the person's underlying circadian rhythm. And I'm hoping that when we do these other experiments that look at meal timing in relation to DILMO, that we can get a little bit more sophisticated about what's the, quote, right time to eat for a given person.
Gotcha. Okay. From Dr. Diaz, the late dinner changes in, and I think this was something that did cross my mind as well. Monsi, we've had some brainwaves going back and forth here. Late dinner changes impact slow wave sleep. And could this have implications for growth hormone secretion and growth in children? Any thoughts on that?
Yeah, that's a good question. I don't know the answer to that. I think that the slow wave changes we saw might be accompanied by growth hormone change as well, but we did not measure that. And we certainly could, although, as you guys probably know, growth hormone is a very tricky hormone to measure. It would require very high frequency sampling because it's secreted in a pulsatile manner. So if the changes that we saw in growth hormone, in slow wave are mediated by growth hormone, then yes, I think there's a role for trying to leverage that for certain people, right? I would identify maybe a few populations, right? There's the maybe sleep onset insomnia phenotype that might benefit from eating before bed, right? If you're trying to increase sleep depth in that patient population. And then there's the endocrine effects, right? There might be a disadvantage to eating late if you're worried about obesity, and that's what we have been showing here. But maybe for someone that's underweight or a child that's growing, that might be appropriate. So again, we don't have the answer to that till we do some more hormonal measurements.
Great. I'd like to ask you a question. When you were showing the graphs related to, say, an early versus the late meal, you were showing the spectral analysis for REM sleep, N2 sleep, and slow wave sleep. And then you made the comment after your colleagues' work regarding doing power analysis. You could see that for those who had late meals, N3 was more pronounced, I think, in the early phase of sleep, and that you said, and you made that comment in terms of the power analysis, and then it looked to diminish. What were the relative, I was looking at those curves thinking about the area under the curve to kind of look at the total percentages. Mm-hmm. And so question one would be, were there any significant differences between the two groups in terms of their percentages of REM sleep and slow wave sleep? And then the next question I will ask as a follow-on to that is to say, do you have any thoughts about when we as sleep clinicians look, a lot of times we focus on a set of numbers, you know, when we'll focus on the percentage of slow wave sleep. Should we be looking at the continuous sleep like in the hypnogram to really try to get a better understanding of sleep architecture? And if you can make any comments on that, much appreciated.
Yep. So you're going to have to refresh my memory. First question.
Area under the curve between early and late percentages of N3 and REM.
Right. So when we look at the macro sleep architecture in the late versus the early dinner, we saw no overall percentage differences in REM, N1, N2, and N3. When we looked with the power spectral analysis, we modeled the changes we saw with the regression model and saw that basically in the beginning of the night, we saw a small, probably 2% change in delta power that over the course of the night began to wane. So by about 4 hours into the night, that delta power difference vanished. So it's not an AUC method, but a similar method where you're looking at sort of a trend over time. That deeper sleep kind of waned as the night went on. With regard to your second question, yeah, I definitely think that the methods that we use to look at sleep depth are probably antiquated in some manner, right? We do it manually. We arbitrarily say 30 seconds is what an epoch should be. It's a carryover from the analog days of the grass recorder speed. Maybe it would be better to look at metrics of sleep depth using more quantitative metrics that actually don't require a human being. You just take the power spectra. And I think there are advocates that are pushing us to do that when it comes to looking at sleep depth and continuity. The trick is always, and we know this in the field, that the number tells us one thing and the patient tells us another. So telling someone that your delta power is this amount or this intensity, what do we do with that? We don't know yet. I think it's good as a research tool if we want to look at objective differences between conditions. And it's also nice because it's dynamic. So for example, in this study, it was not helpful to take a snapshot of the whole night and say, looks like late dinner did nothing to your sleep. That proved to be an inadequately sensitive approach. We had to use delta, we had to use spectral analysis to say that there was an effect. It was small, but it was dynamic. It changed over the course of the night.
Jonathan, thank you